Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Alwyn Abraham from Leicester, United Kingdom. Alwyn has spent 15 years on the trauma and orthopedics front line as a consultant and has recently commenced as head of service for trauma in Leicester. The highs and lows of working in the NHS, notwithstanding, he remains a committed clinician, manager, and a trainer. Clinically, he particularly enjoys the challenge of salvaging infected, traumatized, and deformed limbs in the chosen field of limb reconstruction. His support of the marginalized has driven his enthusiasm for several interesting projects. This has included his advocacy of junior surgical trainees as training program director, the genesis of a foundation doctors program for international medical graduates, and the creation of a specialist orthopedic training program for late entrants into the NHS. Alwyn is particularly proud of his role as co-founder for the Leicester-Gonda Orthopedic Partnership, conceived in 2017. This is a partnership between University Hospitals of Leicester, University of Leicester, and the University of Gondar in northern Ethiopia. In collaboration with Rotary International, $200,000 was raised and have led to several clinical visits to develop orthopedic infrastructure in northern Ethiopia, where up to 7 million people are without the very basics of orthopedic care. The benefits of this program is even more poignant given the number of casualties after the recent civil war in Ethiopia. So today it's my great honor to introduce you to Dr. Alwyn Abraham from Leicester, United Kingdom. Over to you, Alwyn.
Hitesh, thank you very much for this invitation. I'm really very blessed and honored to be able to speak. It's an unusual topic, but I thought I would speak about a condition which very few of us get training in, yet it's a condition which presents very commonly and which taxes us immensely: the management of chronic non-specific musculoskeletal pain in children and adolescents. I wonder how many of you have this view from where you are sitting now. I'm sure there's one orthopedic surgeon with this lovely view. I wish I had this view, but I don't. It's not the view I want to focus on, it's the giraffe itself. The giraffe is a phenomenal animal, it's extremely tall, and it's blessed by this immense height, which means that it can reach the highest, most delicious branches. Unfortunately, the giraffe has a weakness because of its height. As a result of its height, it's extremely vulnerable when it bends down to drink water. I'm afraid that there are certain vulnerabilities that we have as orthopedic surgeons, and I just want to briefly just mull over them before I start my talk. So, we are specialists who deal in high volume treatment. We are specialists who are judged by how efficient we are with our time. Our brain is trained to make decisions quickly. Much of the input, the data that we use to make decisions are visual cues. So examination, a history which involves an injury, x-rays and scans. And most commonly, our fondest outcomes are usually visual, i.e. x-rays and scans, and even better, the post-operative check x-rays. So the issue is that in times when we haven't got an operation, in times when we can't see anything on the examination, at times when we can't see anything abnormal on the scan or the x-ray, we find that a real challenge. And I think that's what Steve Jobs was alluding to when he said strengths and weaknesses are two sides of the same coin. Now, just to clarify, I'm not a psychiatrist or a psychologist. I'm an enthusiastic orthopedic surgeon. And I particularly like limb reconstruction and in-Lazarov surgery. And by just a plug to say that if you would like a helpful patient information leaflet, do use the one that we've designed here in Leicester. Simply type into Google patient information frames Leicester, and you'll be able to access our patient information leaflet, which is tremendously helpful. Also to say that much of what I talk is contained in a chapter that I wrote in this book, so feel free to access it if you wish. I'm also extremely grateful to Springer for allowing me to use this content in this talk today. Those of you who are astute will have realized that I have this 5 takeaways at the bottom right corner of my slide. And that's a subliminal message to say that I wish to make 5 clinical points, which I will highlight as we go through the talk. But before I start the 5 points, I just want to give you one warning. Chronic regional pain syndrome is something that children experience. This is a real scenario, and I have used several anonymized scenario clinical cases that I've come across in my practice recently. So this is an example of a 16-year-old girl who sustained an ankle fracture after a twisting injury. It was a minor fracture. She was treated in a short leg cast, but even after 6 weeks in cast, the pain was very severe, and the pain was severe enough to make her cry. The pain is so bad that it will not allow her to put her limb on the ground. She refuses to weight bear. She refuses to move the ankle. The pain is described as burning in nature with abnormal sensation. An examination reveals skin color changes, pale, changing to purple when the limb is held in a dependent position. And there is the presence of allodynia, which in my book is severe pain caused by cutaneous stimulation. So just to say that chronic regional pain syndrome is seen in children. Fortunately, the outcome in children is much better. You don't get the fibrosis and the contractures that adults get, but it's important to identify it and treat it appropriately. The most important thing is to give an explanation and to give reassurance. So the way that I describe it to parents and to patients is to say that we all have an injury repair mechanism. In some instances, this injury repair mechanism sadly malfunctions or goes into overdrive, and then the healing process becomes the problem. And that's my explanation to parents and children about what CRPS is. Fortunately, it responds to physiotherapy. It responds to desensitization. Something very simply that parents can do is to simply undertake a period of massage at home. It's amazing how many children simply refuse their parents to touch the injured leg, and parents will often remark on that. And starting this process of desensitization massage at home is a really good first step in overcoming CRPS in children. So here's a clinical example of something that might occur, cyanosis, venous congestion in a dependent position. And that's a really good sign that this child might indeed be suffering from CRPS. So that's the warning at the start of my lecture. And now I'll go on to describe 5 clinical scenarios which you will undoubtedly come across in your practice. So these scenarios are, number 1, growth-related pain in teenagers. Number 2, chronic apophyseal injury, usually in teenagers or juveniles. Number 3, benign idiopathic nocturnal limb pains of childhood, commonly known as growing pains. Number 4, joint hypermobility syndrome. And number 5, central sensitization disorder, which some of you might have come across. So first one, growth-related pain in teenagers. So here's an example again. Got a 14-year-old girl being referred with bilateral knee pain for a couple of years. She's aggravated by exercise. And that's usually the key thing in the history, is that there isn't a specific injury that has triggered this pain. In fact, most patients can't recall when the pain first started. That's how nebulous and insidious it tends to be. During the summer holidays, i.e. during periods of relative inactivity, then patients like her will say that they have minimal pain. The pain gets worse after physical education, especially when running. On examination, her knee will be completely normal, other than a definite hamstring and quads tightness, which I will go on to explain shortly. She received advice on stretching exercises and a short course of physiotherapy. Adherence to stretching and physiotherapy was emphasized as being important for recovery. And this is a scenario that many of you will have come across. The common sites of growth-related joint pain in children is the knee, most commonly. In some kids, especially in females, you will get hip pain, and very rarely you will also get back pain. And back pain in teenagers used to be considered a red flag, no longer the case. Many of us realize that mechanical bog standard back pain can also affect adolescents. It's really important to appreciate that the knee is the zone of maximum longitudinal growth in teenagers. The distal femoral physis grows at 1 centimeter per year until skeletal maturity. The proximal tibial physis grows at a rate of 0.8 centimeters per year. So it's a zone of maximum growth. And so the soft tissues are really getting stretched. And that's usually my explanation as to why children have anterior knee pain. In some females, you will get hip pain, often associated with the clicking of the psoas or the iliotibial band. And this again is usually due to increasing pelvic width as the human body gets prepared for a reproductive phase. Increasing pelvic width therefore causes the snapping of the psoas tendon over the femoral head. And children can often reproduce this with a Leadbetter type maneuver. And children can often also reproduce the ITB lateral snapping sensation by externally rotating the trochanter against the iliotibial band. So these are the common sites of pain. And my advice is that you undertake a hamstring assessment in all of these children. This is really easy to do. It's called the popliteal angle. And the ideal popliteal angle, especially in children who are doing competitive sport, should be essentially 0. So if you're playing competitive sport, you should be able to get your tibia absolutely vertical when your hip is flexed at 90 degrees. And anything more than 30 degrees is likely to cause you anterior knee pain, growth-related knee pain due to hamstring tightness. I think this is a bit of exercise advice that I can give all of you. If any of you run or do exercise in your adult years, please check out your hamstrings, undertake a period of stretching, concentrate on maximizing your hamstring stretch, and you'll realize how much benefit you have in terms of reducing knee pain when you run, when you jog, when you do whatever exercises you do. I'm very proud to say that my popliteal angle is about 10 degrees, and I've consciously worked very hard on keeping my hamstrings flexible, even at this age. The other test that's worth doing is checking the tightness of quadriceps. So you can do this by putting the patient prone, and you're looking for the buttock, the gluteals rising as you hyperflex the knee. And that's a sign that the rectus particularly is tight. So that's growth-related pain. The next point I'd like to make is about chronic apophyseal injury. And as the name says, this is pain at the sites of an immature apophysis. So where a growth plate is attached to a major tendon, with the growth plate still open because skeletal maturity is imminent. And this applies to the heel, so the os calcis, where the TA inserts into the heel. This is relevant at the knee, where the patellar tendon inserts into the tibial tuberosity epiphysis. And those are the two sites of pain that I refer to when I say chronic apophyseal injury. So here's a classic case of an 11-year-old boy who's a keen footballer, presents with a painful heel, and the pain is often brought on by running, jumping, and other sports-related activities. It's started on one side, but both heels are painful now. With the right side worse, he limps, sometimes walk on his tiptoes. And you'll see some children undertake this slightly maladaptive behavior because they realize that putting the heel on the ground hurts. So then they develop this maladaptive behavior of preventing pressure on the heel as a result. On examination, there will be a little bit of pain when the heel is squeezed, but often when you examine these children, they are absolutely free of pain because the pain is associated with exercise. So they'll get pain at the end of the game. If they are a footballer, for instance, they'll get pain in the evening when they go home, and they'll have a little bit of pain the following morning. But usually within a period of 36, 48 hours, the pain has completely subsided. And that is a key to diagnosing chronic apophyseal injury. As I will mention later, some of these children develop very severe maladaptive behaviors, and this becomes a major chronic pain, which I will address towards the end of my talk. But this scenario that I've just described is obviously classic of Sever's disease, which many of you will be familiar with. And this is how you check for tenderness. So you might not have tenderness when you're examining the child, but if you ask, is this where the pain hurts? That's exactly where they will say the pain is when they run or they jump. It's important to check the tension in the tender Achilles, and if it's tight, the test that we describe is the silver skulls test. So you're looking for dorsiflexion of at least 20 degrees with the knee extended. With the knee flexed, you will get more dorsiflexion, but with the knee extended, you should have at least 20 degrees of dorsiflexion. And if the child hasn't got that, then you're looking for a specific exercise stretching regime to increase that dorsiflexion. One very simple exercise that children can undertake with Sever's disease or with TA tightness is just undertaking a daily regimen of a full squat. And by a squat, I mean buttocks right down to ankle level with the heel remaining in contact with the ground. Classic Indian squat is a great exercise to stretch the Achilles tendon. One very useful tip that I find to make this to help with the explanation to parents and to children is to show what an X-ray of os calcis looks like in a child. So I usually type into Google X-ray calcaneum, and then I bring up a second window, X-ray calcaneum child. And it's really useful for parents and children to know that there is this thing called an epiphysis, a growth plate, and the X-ray is maturing from the childhood X-ray, the one on the right, into a more adult type picture by the age of 15 or 16. And that understanding that they get from simply showing an image makes a huge difference to them appreciating that this is a transient condition. It will get better in time. Incidentally, most Sever's disease is between the age of 8 and 10. It's very rare to get Sever's disease after the age of 11, certainly. So all of these conditions that I described, chronic apophyseal injuries for certain, they're all time-limiting conditions which will get better with time. So the third condition that I'd like to talk about is growing pains or nocturnal pains. It has a long, complicated technical name by the way of benign idiopathic nocturnal limb pains of childhood. And this is a very typical scenario of such a presentation. So you have a little boy who comes in with his parents. He's about 5 years old and he's doing really well academically. And in terms of his development, his health will be very good. He'll have pain classically at night when he's asleep. And when he's sleeping, he will cry out in pain and his parents have to go across into his bedroom and comfort him. And well, the site of the pain will be quite vague. The child will either point to the foot or will point to the shin, and parents will rub it, they will massage it, and the child will say, yeah, fair enough, the pain's got better, and the child will then fall asleep. And this scenario of nighttime pain can be really very intrusive. It can happen every night for days on end, and it's really very distressing for the parent. The child will be absolutely fine in the day, and often they will not even remember the fact that they were crying during the night. But the parent who's been disturbed, regularly at night, will be beside themselves with distress because the child is in pain. It's really important to consider the age of presentation. So this is classically a condition that presents between the age of 3 and 7. It almost never presents in 9, 10, 11-year-old children. Why do parents present? Well, they present, as I said, because their own sleep is affected. You know, imagine being a busy professional and your child is waking you up every night with pain. It's really very distressing for the parent. And it's not a great way to get ready for work the next day if you've got disrupted sleep, on a regular basis. So what should you do as a clinician? You should always exclude significant orthopedic pathology, and that is, that the onus for that is on all of us to do a full history, a full examination, make sure this child hasn't got cancer, make sure this child hasn't got infection, make sure there isn't an injury or any other condition that might explain this pain. But almost invariably with the scenario that I've just drawn for you, the investigations and examination will be negative. What mustn't you do? Well, you mustn't ascribe this to some kind of myth. You must say that pain will get better. You must keep it quite vague, and you must say that the pain is likely to get better gradually over the course of a couple of years. And the bottom line, therefore, is reassurance. Fourth condition that I wish to talk about is a joint hypermobility syndrome, JHS, and it's also known as hypermobility Ehlers-Danlos syndrome type 3. This would be a very typical scenario for a case such as this. So you can have an 8-year-old boy who's brought in because he's extremely clumsy, he has very poor exercise tolerance, he tires easily. His early motor development was normal, but advanced motor skills such as hopping, and most children learn how to hop by the age of 4. Most children learn to ride a bike between 4 and 6. You'll find that some children are simply just delayed with this hopping and advanced motor skills such as riding a bike. Parents will say he's got a very clumsy running style, that he's slow and ungainly. They might also say that his pen grip is unusual and he tires very easily when writing. And on examination, what you might find are the signs of joint hypermobility, which I will touch upon in a minute. And what you can also detect is a phenomenal range of hip internal rotation, which means that he can sit in the so-called W position. What is the W position? The W position is this here, with a huge range of internal rotation, secondary to hip anteversion, and an element of joint hypermobility. And some of these children who are hypermobile will be able to contort their bodies into other positions, such as this one here, which is, you know, a classic yoga sleep pose. So some of these children can do other tricks and you know, party pieces where they can do some kind of contortion with their leg. And that, again, is a clue that you're dealing with a child who has hyperlaxity. What does this result in? Well, it does mean that parents are extremely concerned. They catastrophize. They're convinced that there is some kind of condition which needs to be treated. And what they need explanation about is that this is a condition which is a variation of normal, which means that they have a slightly different type of collagen, proportion of collagen type 1 to collagen type 3. And as a result, some of their physical abilities will be not necessarily reduced, but different to many other children. You know, we'd all like to be Usain Bolt or Cristiano Ronaldo, and that gives me away as a Manchester United supporter, so feel sorry for me currently. But the fact is that children are born differently, and many of them will not have the explosive athletic ability that some of their peers will have. And that's a really important thing to emphasize to parents. It's also really important to emphasize to parents that even though this child might not have explosive athletic ability, they will be able to do other activities which is better than their peers. So, you know, many of them will be able to do yoga really well, be able to do gymnastics really well. Many of them will be able to swim really well. And so there are these alternative activities that these kids will be very good at. It is known to have, JHS is known to have a genetic basis and often runs in the family. And in the UK, many lay people will recognize JHS as a child being double jointed. So to diagnose JHS, that we have a Baton score and we have a Brighton Diagnostic Criteria. What is a Baton score? Well, many of you will be familiar with the Baton score because it's simply a measure of hypermobility. So hyperextension of the thumbs, hyperextension of the fingers, hyperflexion of the lumbar spine, and hyperextension of the elbows and knees. And if you have a score of more than 4 out of 9, then you're looking at someone with hypermobility. The Brighton Diagnostic Criteria is the diagnostic criteria for JHS, joint hypermobility syndrome. And this is when hyperlaxity now becomes a clinical condition affecting children. So we use major minor criteria, so the hyperlaxity counts, and other symptoms such as dislocation, subluxation, rectal prolapse, presence of headaches, abdominal pain. All these are now confirming that it's not simple hypermobility, but in addition to hypermobility, you've got a syndrome of MSK limitation because of an underlying condition. One practical thing that you can advise is you can advise children to get fitter. So they might not be able to develop the explosive speed and coordination of other children, but they can certainly improve their fitness. And I use this exrx.net website to guide children. It's a free access website. And what it does is it gives you a guide to what children can aim for if they want to improve their fitness. So down in the bottom left corner, you can see fitness calculator, and it gives you what a child should roughly be able to do for their age. So just using running as a measure, you can say that, you know, a 12-minute run in boys aged 13 or older should take about 2,500 seconds, and you can measure children and you can give them targets, and feedback is best when it's good quality and when it's timely. So this is a way that children can improve their fitness by measuring themselves against population norms. Finally, my final point that I wanted to talk about is something that perhaps many of you might not have come across, and it's called central sensitization disorder. And here's a classic example of a boy who is obviously very distressed. 9-year-old boy, due to start a new school, presents with a 6-month history of bilateral symmetrical lower leg pain. The pain is only present after sitting for a prolonged period, followed by standing. Sometimes he's in tears. He's been unable to attend the school of his choice. In 2016, at his current school, there have been a few instances of confrontation with staff, teachers, and students. His older brother has been unwell with renal calculi. He's otherwise a fit and healthy boy. He sleeps well. He's fully independent for ADLs, even with his pain. He can manage stairs, but sometimes he has to crawl up stairs. Examination is unremarkable with full range of movements in all joints. In particular, there is no abnormality detected in the legs. And this is a classic syndrome of pain with no physical explanation, which some of you, I'm sure many of you have come across. And it's a real difficult scenario for us because we are, as I said at the start of my talk, we are used to detecting visual cues. We are used to detecting something that is visible on a scan or an X-ray, and then we are trained to take action on that basis. And clearly, this type of scenario doesn't fit our training, and so we find this a particularly difficult condition to manage. If you want to learn a little bit more about central sensitization, I can recommend this YouTube video. It's about 4 minutes long. It's free access. And it'll help you understand a little bit more about how the brain sometimes misrepresents what's happening in the physical domain. What is central sensitization? Well, it's put very simply, and it's important to explain to parents. It's really important to explain that we all have pain for a reason. It's a protective sensation, but sometimes that protective sensation goes into some kind of hypersensitivity, and it fails to reset after a previous injury. And this phenomenon is called wind-up, and many of these children will have allodynia, hyperalgesia as a result of central sensitization. Allodynia, it's important to document the presence of allodynia, because if you've done the right treatment, if they come back in the future, then you can you'll be able to compare what you say today with what's happening in 4 or 5 months' time. Allodynia is an unpleasant, intrusive sensation, and it's usually brought on by simple, innocuous physical stimuli such as touch or stroking of the skin. And hyperalgesia, that's an exaggerated severity of pain from an otherwise normal movement, such as you might get when you move a knee or an ankle. So these are the components of central sensitization, and these are important things to explain and document. Another way to explain to parents is an analogy with dyslexia. So I don't know how many of you might have dyslexia or know people who have dyslexia, but if you ask a dyslexic person to look at the alphabet, what they will see is a combination of quite unusual shapes and symbols. There's nothing wrong with the eyes in dyslexia, it's how the brain's processing it. And I find that a useful analogy to make when I'm explaining to parents that their child might have a central sensitization disorder. How do we discuss this with patients? It's very difficult to tell a parent that this child has a condition which does not need surgery. This child has a condition for which there is no specific treatment. But it's important to break this information like you might break bad news. So in the way that a cancer surgeon might break the bad news of terminal cancer to a patient, I think in many ways this is our equivalent in orthopedics, and especially when it comes to dealing with children. So it's saying that you have a condition for which there is no obvious physical cause. There is something awry with the pain censoring and pain processing mechanism. And I think it's really important to emphasize that there is usually success with recovery, that recovery is gradual, that recovery is usually over a period of several months, with complete resolution often achievable. And I think with this explanation, with this understanding, with reassurance that there is no other medical condition underlying, I think most parents and most patients will respond to and engage with appropriate physiotherapy and exercise therapy. I think it's really important to not label the child as making up the pain. This pain is very real. And another analogy I make is with phantom limb pain, which people get after an amputation. And I think central sensitization is pain very similar, present with no obvious physical stimulus. I think the important thing in terms of treating central sensitization is to emphasize that exercise is good, that the brain needs to reset itself, and the only way it will learn to reset itself is if the limb is put through its paces, if the body engages with exercise and the brain relearns the normal sensation, the normal range of movements in a gradual fashion. So physiotherapy, exercise therapy, and you simply writing out a gradual increasing program of exercise for the patient is a classical way for these kids to recover. I think it's really important that these children are managed in this fashion, in this kind, caring, empathetic fashion. Hence my use of the word rediscovering your empathy at the start of my talk, as a title of my talk, because I think children will respond to that kind of kind, caring approach to managing this. And it's really very useful for them to come back after a period of a couple of months on a regular basis to show you that they are improving. I think it's good for them. It's also good for you. But most important, it's important that we don't propagate myths about, something being seen on the scan. There are many instances when scans and x-rays might be helpful, but equally incidental findings confuse and muddy the picture. And it's important that is managed at source. So just to conclude, I think it's really important to appreciate that the young brain is very complex when it comes to perceiving and processing pain. I think the young brain is also very confused easily by what it senses from parents, their frustrations, their uncertainties. And some parents are very well-meaning but end up protecting their children in the face of minor pain, and the pain mushrooms, it becomes bigger with major maladaptive behavior and effects on schooling, family life, relationships, etc. It's really important, as I have mentioned in the talk, for you to do a thorough orthopedic exam. There is no excuse for missing infection, cancer, or injury. Many patients with complex pain will have cancer on their mind. They will have heard of cancer. They will have heard of bone cancer. They might know someone who's had cancer, and they want you to tell them that their child hasn't got cancer. And I usually often spell it out to them in those words. I usually say, your child hasn't got cancer. Is that something what you were thinking of? And in many cases, the answer is usually yes. Negative investigations must be interpreted judiciously. So watch out for the incidental finding of a fibrous cortical defect or a bone infarct or something like that. And that mustn't then be attributed to being the cause of pain. It's interesting, especially with knee MRIs, you will see lots of cases of osteochondritis dissecans. And in my opinion, osteochondritis dissecans is probably underdiagnosed. I suspect many kids have osteochondritis dissecans, but it's amazing how many episodes of knee pain are attributed to osteochondritis dissecans because it's become such an easy condition to see on sequential MRI scans. I think in terms of managing these complex cases, I think the key is your clinical acumen, that you give the parents confidence that you've checked everything appropriately, you've excluded major conditions, and that you genuinely believe that there is pain which needs gradual treatment and that which will gradually make a complete recovery. So just those 5 conditions once again. Growth-related pain, we talked about hip pain in teenagers, we talked about knee pain in teenagers. I just remind you once again the usefulness of learning how to do the popliteal angle examination and prescribing hamstring exercises in teenagers. Chronic apophyseal injuries, I've mentioned about severs in particular. The other one that you'll be familiar with is osteostratus. Again, this is a self-limiting condition. It's important to reassure patients, manage them, reassure them, and prevent precipitation of maladaptive behaviors. Nighttime growing pains in children, remember, it's not the child who's suffering, it's the parents, the constant waking up in the night, the worry, and it's the parents that you need to reassure and tell them that everything's going to be okay. Joint hypermobility syndrome, remember that we're not all born the same. Some of us have more movement in our joints than others, and it's important that this is explained in that fashion, that alternative exercise regimes are prescribed, and that patients' expectations are managed appropriately. And finally, central sensitization disorder, which can take on many different forms of presentation, and which is essentially the childhood equivalent of phantom limb pain and needs to be managed as such. I'd like to just dedicate this talk to Dr. Lynn Staheli. He was a children's orthopedic surgeon in Seattle. I met him very briefly on one occasion. And what struck me most about Dr. Staheli's career was that he dedicated his life to the conditions which are not fanciful, which are not sexy. He talked about genu varus, genu valgus, normal variations in children, because he realized that children were being maltreated or mistreated because of several myths that had perpetuated in orthopedic literature over generations. So my dedication is to Dr. Staheli. Why does this all matter? Well, you know, there is an epidemic of opioid use, both in adults and children. In a very worrying study, a 20-year study between 1999 and 2016, there were 400,000 deaths in the USA as a result of opioid misuse. And I don't mean social opioids, I mean medical opioids. That's a really worrying figure. If 400,000 patients are dying from opioid misuse over a period of 20 years. Even more worrying when I tell you that of those 400,000, 8,000 were children. That's even more worrying, isn't it? And this doesn't take into account the children whose lives and schooling has severely affected by MSK-related pain. So it's on us as orthopedic surgeons to manage this appropriately. I talked about rediscovering your empathy, and I hope you'll think over that over the next weekend, perhaps, or as you wind down and relax from your practice. And if nothing else, I think adopting a little bit more empathy will help you manage cases such as this, but it will also help you manage your children better. And maybe one day your children will turn around and say, Dad, I thought you were an orthopedic surgeon. You sound more like a psychologist. Thank you very much for your time.
Thank you, Alwyn, for that brilliant talk of yours. Very, very informative. A couple of questions from our side. Alwyn, you mentioned about Sever's disease as a cause of heel pain, right? So do you really need to see fragmentation and sclerosis to make a diagnosis of Sever's? Can it be like someone who is a runner or someone who's jogging, they develop a kind of stress syndrome, like how you get the medial tibial stress syndrome?
So my answer, the answer to that question is to say that Sever's disease is a purely clinical diagnosis. In fact, I use those X-rays purely as an illustration. I do not routinely request X-rays for Sever's disease. It's classically a pain in that age group, which I mentioned, between 8 and 10. And it's nearly always pain during the activity. So children will be very happy to go to their, sports activity. They'll be very happy to go to their games lesson. They'll be very happy to go to their PE lesson. The pain is usually at the end of the lesson, and they'll be limping at the end of the match. And sometimes the coach or the instructor has to substitute them because they're getting pain during the game. And the pain is worse in the evening or the end of the day. But again, as I said in my talk, within 36, 48 hours, you'll find that these children are always better. So these are questions that you need to ascertain in the history. It's not an X-ray. It's not an X-ray based diagnosis.
So it has a strong correlation with the activity, right?
Absolutely. And in every case of Sever's, you will, if you ask the correct questions and you ask the questions almost forensically, the child will say, at the end of the game, I'm in a lot of pain. The next morning, it is better. And the next morning, yet again, so after 36 hours, I'm completely free of pain. And if you ask the question in that sense, you will almost always get that answer.
No, the reason why I asked is, does it come under the spectrum where there's a compromised blood supply? For example, you get an Osgood-Schlatter, you get an Perthes. So that is a different kind of spectrum, isn't it? Sever's.
No, I know what you mean. You're wondering if it's an osteochondrosis condition, but I would say it's more of a apophyseal injury, a chronic apophyseal injury, and that's its basis. I wouldn't say that it's like Perthes. I don't think it's a vascular phenomenon like Perthes. And to be honest, I might be controversial here, but I'd say Osgood-Schlatter again is not vascular. It's a traction apophysitis. That's the basis of it. Thank
you, Alwyn, for that. The other very common, you mentioned about CRPS or Sudex osteodystrophy, reflex sympathetic dystrophy and what is a typical age group do you see in children less than 10 years or maybe in their adolescence or late adolescence?
Yeah, and it's really interesting, isn't it? I mean, if you do adult orthopedics, you come across cases of CRPS. And there is no obvious explanation why some people get it and some people don't get it. The vast majority, fortunately, the vast majority of people that we treat never get it. So it's a very small minority who get it, and it's really unfortunate. I'm going to speculate here. I think there's a huge personality, psychological aspect to CRPS. It's almost like some people have got so wound up that their autonomic control has been lost, and I think that's why some people get CRPS, because there is no other explanation as to why it's so random. What I would say is, for instance, people come off their motorbike at like 100 kilometers an hour, they don't get CRPS. Yet, you'll find someone who's been, squashed by their boss and they have CRPS after an ankle sprain. It's a really bizarre condition, isn't it? I think there's an element of this secondary gain, and that's why some people get it. And it's almost always in teenagers. You will never get it in you'll almost never get it in children under the age of 10. So there's something very specific about older children and adults, which means that they are predisposed to it.
Thank you, Alwyn, for that. Just one last question before we wind up the session. Alwyn, you brought out this entity called a central sensitization disorder. I mean, this is not very commonly discussed in orthopedics. Like you said, it's not part of our training, right? And two very important terms, hyperalgesia, allodynia. And these are part of a spectrum. Is it a more generalized form of RSD? Okay, the same hyperalgesia, allodynia, you can get in localized in RSD. And when you talk about central sensitization disorder, you say, okay, that can be in a generalized form. Do you think it's a part of a spectrum?
It might be part of the spectrum, but I would say that the classic difference is that in central sensitization, you don't get the autonomic dysfunction, which is what you get in CRPS. So if I was to look at a child, I would say that I have an almost routine algorithm. So number one, I'm looking for, obviously exclude an orthopedic condition, injury, fracture, whatever. That's number one. But once you're beyond scans and x-rays being normal, then the first thing I look for is there autonomic dysfunction. If you've got autonomic dysfunction, and that classic picture that I showed you of the cyanosis, venous congestion in a dependent position, then I'm going to label that case as CRPS type 1. If you haven't got that, then I'm going to label it as central sensitization. And you could say it's part of a spectrum. Yeah, it might well be part of the spectrum, but the difference is the absence of those physical signs and the autonomic dysfunction that you get in CRPS type 1.
Thank you, Alwyn, for that. Just before concluding this, I just want to ask, do you get a psychological evaluation for patients who have a central sensitization disorder? Do you consult it with the psychologist?
To be honest, I don't think there is much role for doing that at the start. So I think it's really important for us all, and orthopedic surgeons as well, to appreciate that worldwide, apart from COVID, the other pandemic is mental illness. And whether we like it or not, mental illness comes into our orthopedic consultation rooms, and it presents in a multitude of ways. And there's, as I mentioned before about CRPS, there is definitely an overlap between central sensitization and the early onset of mental illness. So mild depression, generalized anxiety, these can often manifest with physical symptoms, and central sensitization pain in children can be one very early first presentation of mental illness. And don't forget, if you look at mental illness, 50% of mental illness in the long term in adults has its onset in teenage years. So that's a really worrying thing. But your question is, do I get a psychological assessment? The answer is, I think for the vast majority of cases, I feel really confident that just with that discussion, reassurance, simple follow-up saying, I'll see you again, I'm here to help you. I think in most cases that works. I think there are some really strange personalities and some really strange family dynamics, when there is, say, complex bereavement, when there is marital separation. I think that is much more complex, and that needs a psychologist. And in those cases, when, I have a child who's in a wheelchair and I haven't got any explanation, I think it's those cases that I will send to a psychologist for further evaluation, because it's obviously something much more complex and one that I can't, manage myself.
Thank you, Alwyn. I think that's all the questions that we have for this session, Alwyn. Thank you for the fantastic talk, and I'm sure this is going to benefit a lot of people all over the world.
Thank you, Hitesh. Absolute pleasure. And can I just say I'm a huge fan of the initiatives that have been taken by orthopedic principals to make education such an easily accessible thing for professionals around the world. Amazing work.
Thank you so much.